She's given over 40 medical lectures, written over 15 peer-reviewed articles. She's been awarded for her teaching several times, including Outstanding Medical School Teacher, Best Doctors in America, and Outstanding Medical School Teacher. I did my training at Medical College of Wisconsin, and Dr. Wilson, in terms of loving her patients and seeing them as humans, she taught me that. And every day in my clinic, I hear her voice in my head saying, look at the whole picture, different diagnoses. I saw a patient this last week with Sweet syndrome, and I heard her voice say, mammillated juicy papules, and which you wouldn't understand if you don't know Sweet syndrome. But I'm excited to hear her speak, and I think it's a real treat. So thank you so much.
Thank you, Adam. Thank you. Got the clicker. It worries me that he hears my voice in his head, but I am very happy to be here. I am so proud of Dr. Tainter and the role he is taking in this society, and I am proud to be his retired residency program director. I am a complex medical dermatologist. I don't do children, I don't do path. And so what you're gonna learn today is, I hope, pearls that will help you with your patients where internal medicine and family practice and derm intersect. And Dr. Tainter has given me a high order. He has asked me to do 50 pearls in 60 minutes, which means we are gonna fly. Don't worry if you don't digest everything. It is in your PDF with some embellishments. So just try to look at the pictures and sing along, okay? So we're gonna start with connective tissue disease pearls. The first pearl is that there are 3 big subsets of cutaneous lupus from the dermatologist's point of view. They are acute cutaneous lupus, subacute cutaneous lupus, and chronic cutaneous lupus. If you can keep that straight based on epidemiology, serology, clinical appearance, it will help you to understand what kind of lupus this patient has. This Venn diagram is really good. The large brown circle on your right are people who qualify and meet criteria for having systemic lupus. So these are people, whatever criteria you use, who have SLE. And you will see that acute cutaneous lupus lives right inside that circle. You just don't see it in people who don't have SLE. Subacute cutaneous lupus bridges the two. And chronic cutaneous lupus, the most common of which, I know you have seen discoid lupus, resides within the pink circle, which is people who don't meet criteria for SLE and only have cutaneous disease. Okay, what does acute cutaneous lupus look like? Young women, think young women, young African-American women, but any young woman. It is non-scarring, it resolves. It is what you think of as the butterfly rash, the malar rash across the bridge of the nose and including the bridge of the nose, and it can be more generalized or photo-distributed. Compare that with subacute cutaneous LE. I know you have seen this because this is increasingly common. It tends to be these unusual annular or ring-like shapes or psoriasiform shapes, and instead of involving the face, it's more common on the chest, the upper back, the arms. It is also characterized by the fact that it tends to have a different serology pattern with SSA, SSB. Okay, here's more of what it looks like. It's a very distinctive rash. When you see this, you should be thinking subacute cutaneous LE. And then discoid lupus, I also know you have seen because this is common. This is the face, the ears, the scalp, the arms, generally like the upper trunk and upper body. The problem with discoid lupus, remember, these people don't usually meet criteria for SLE, they're not sick. The problem with discoid lupus is it scars, and it scars badly. So if we don't intervene, it leaves these horrible scars. These are all patients of mine with discoid lupus, and you can see how disfiguring, particularly the dyspigmentation is. All right, and the scarring alopecia on the bottom. All right, another mini pearl, always look in the patient's conchal bowls if you think they might have discoid lupus, because it very frequently is found there. All right, pearl number 2. When you see this unusual subacute cutaneous lupus, I want you to think about drug trigger. We are increasingly realizing that it is started by drugs, and you often need to take that drug away for the patient to get better instead of layering on treatment. Usually 6 weeks or longer after the drug was initiated. Otherwise, it is indistinguishable from other forms of subacute cutaneous lupus. Okay, what drugs? This is why this is important. These are drugs you use. Patients take a lot of proton pump inhibitors. They take a lot of calcium channel blockers. They take a lot of hydrochlorothiazide. But the list is very long. Don't ever use my slides for a list. There are other places to look that up. All right, pearl number 3, drug-induced subacute cutaneous lupus that we just discussed is not the same as the drug-induced lupus you learned about in medical school. They are 2 different categories. The drug-induced subacute cutaneous lupus, you'll have that peculiar annular rash, typically no systemic symptoms, usually don't have SLE, have a positive SSA, SSB, whereas drug-induced LE, these patients as a opposite don't usually have skin disease, but they have a lot of systemic complaints: weight loss, hepatitis, serositis, pleuritis, arthritis. These are the ones with the antihistone and sometimes even a full-blown lupus picture, and they are a different kind of drug. So try to keep the 2 separate. All right, pearl number 4, dermatomyositis, which often is difficult to diagnose, but an important disease. Dermatomyositis is distinguishable from lupus clinically if you know some of the finer points, and I'm going to try to teach that to you. One of the things we talk about is that in SLE, that butterfly rash bridges the nose but spares the nasolabial folds. And in people who have dermatomyositis, you'll tend to see more sparing of the nose and involvement of the folds under the nose. We also know that SLE will give you rashes between your knuckles, whereas dermatomyositis tends to be over the knuckles. We also know that dermatomyositis, the reason it fools you is because patients come in itchy. They often are itchy. And as a matter of fact, the pruritus and the frictional things that they do to manage that itch are maybe the reason why you see the rash where you see it. So when you see the eyelid rash, eyelids are actually photoprotected. That's not from the sun. It may be from rubbing eyes or blinking. Gauthron's papules, once again, over the knuckles and the elbows, the shawl sign across the upper back, the holster sign on the thighs, and the scalp involvement, and I'll show that to you. So here's their eyes down on the lower right. Sometimes patients have a lot of edema too, so don't let that fool you. Gauthron's sign is when you don't see the papules, you just see the erythema. But once again, this isn't photo distributed over your elbows. That doesn't make sense. So think friction and think pruritus when you, not every patient is pruritic, but think of it. And then the Gauthron's papules over the knuckles. Here you can see the involvement up the tendons on the hand, that itchy scalp that patients will have that is often mistaken for psoriasis. And then lastly, the holster sign on the hip. Actually, not lastly, the famous shawl sign across the upper back. So when you see this, and it just doesn't seem like it's typical dermatitis, try to remember it might be dermatomyositis. Okay, pearl number 5. I'm very pleased to see that many of you will be trying to learn to use a dermatoscope, but we do like to remind people that your ophthalmoscope will work for looking at nail folds. So when you see people that you think might have a connective tissue disease, early scleroderma, dermatomyositis, limited scleroderma, you might see these hyperplastic or ragged-looking cuticles. And if you take out your ophthalmoscope, it can work as well as a dermatoscope. What you're looking for is what we call nail fold capillaroscopy. If you start on your upper left, you see a normal nail fold. Look to the right of that, starting to look like some of the vessels are large. Then on your lower left, really large and tortuous. And on the final lower right, in the middle, you see the dropout, meaning you see white, red, and that's not a normal nail fold. We see that in people who have connective tissue diseases. You can also see hemorrhages in the nail fold, as shown on your right. So use your ophthalmoscope until you buy an $800 dermatoscope, or maybe more, I'm not sure. Pearl number 6, all adult dermatomyositis patients need a workup for cancer. This is where your partnering with us and being astute and paying attention is really important. And that's because 20% of all adult dermatomyositis patients will have or will develop an underlying cancer within approximately the next 5 years. That's a very high number. Many kinds of malignancies are seen, so this is not easy to say, oh, do a workup. We struggle with what that workup would be, but I do want to underline the fact that ovarian cancer is particularly common in women and often requires a transvaginal ultrasound in order to detect not just a CT. Okay, so as I said, you got to work them up for cancer, but what cancer workup do you do? We've really had a difficult time with this topic, and I do have a paper on the next slide that is sort of the paper that I go to now for knowing what to do. But you guys are better at this than I am as primary care doctors. You always go first by the patient's family history, their age, and what is age appropriate, and what symptoms they're telling you that they have in order to know how to look for cancer. But in addition to that, the experts are now telling us that we can also get clues from something called myositis-specific antibodies, which are specific antibodies that will tell you who's at risk. And there are certain things that make us worry more if the patient comes in with bad dysphagia or skin necrosis. So this is the paper, and it at least it's the one I use now. It is in your handout, and this is an international guideline that stratifies the risk of dermatomyositis patients. All of them need a cancer workup, but some of them need more than others. And so this stratifies people when you read the paper based on what antibodies they have, what their clinical appearance is, and other things that tell you how to go beyond just age-appropriate screening. Almost all dermatomyositis patients are going to fall in that pink box. By the way, this paper is about all inflammatory myopathies, and that's why people with polymyositis don't have the same risk for cancer. So that's why it seems confusing that there are low-risk people. But dermatomyositis is in the pink box. Do not read this vertically. On your far left, it is your basic cancer screening. In dermatomyositis patients, you're going to be doing mostly the basic and the middle square, which is more advanced. And then it's repeated based on what the patient needs. Okay. Pearl number 7, you also have to work up all of those adult dermatomyositis patients for interstitial lung disease. Why? Because it's sneaky and because it's the #1 cause of death in disease-specific dermatomyositis, and it occurs in up to 30% of the patients. It can start with mild dyspnea, a mild dry cough. It tends to be delayed, maybe a year or a year and a half, and it can also be quite rapidly progressive. It is associated with some special subsets of myositis, but basically all patients, regardless of their myositis antibodies, you're going to screen. So how do you screen? The experts say the most important thing is baseline PFTs. If they're abnormal, you repeat them in 3 months and keep following them. If they're abnormal, you do a high-resolution CT because it can tell you the difference between fibrosis and inflammation. And basically, you don't need a lot of chest x-rays, bronchoscopies, biopsies, unless for some reason your pulmonologist thinks you need it for another reason. And then one recent paper says ferritin is a pretty good test for following the activity of interstitial lung disease. So you can use that test adjunctively, not diagnostically, but to follow. All right, we're going to go to adverse drug reactions, dermatologist playground. They are very, very common in our ambulatory and ER settings. I know you see them all the time. It is also known that about 25% of adverse drug reactions that end up in the hospital are primarily for their skin, which is why I say it's our playground. Because that is true, we really need to understand better than we do which of these reactions are really allergic and therefore the patient should always avoid the drug, and which ones are truly hypersensitive. As you probably know, those hypersensitivity reactions like toxic epidermal necrolysis, Stevens-Johnson, DRESS syndrome, those are actually more poorly understood than our true allergic reactions. But we do need to be able to recognize them because in the case of these reactions, a patient can never have the drug again. At the same time, we know that erroneous labels of antibiotic allergy are absolutely rampant. According to our friends in allergy and immunology, who have published widely, only about 5% of people whose chart says that they're allergic to penicillin truly are. And only about 2% of those people who are truly allergic to penicillin will cross-react with cephalosporins. That's an old paradigm shot down, okay? We also know that people who take sulfonamide antibiotics and have allergies can still take other sulfa drugs like sulfonylureas, but we don't practice that way. So we also know that harm is being done by erroneous labeling. We've got antibiotic resistance, we've got cost, we've got problems with the patient getting broad spectrum antibiotics, we got longer hospitalizations. There's just a lot of literature on this. So here is my pearl. At least acknowledge, and maybe in your head, join the delabel movement. What is this? This is actually a movement headed by Immunology and Allergy, published in HHS. If you want to look it up just on the government website, you can see their original papers about how to do this. The whole idea is it starts with a chart review. You have your annual checkup with the patient. You go over their allergies. You don't just say, oh, it says you're allergic to penicillin. You ask them, what do they know about their penicillin allergy? And try to delabel them if it's an unreliable, or maybe they'll tell you they had a stomach ache. Try to delabel when you can. And if it's more complicated than that, these papers lay out how you can easily re-challenge them in the office, or even desensitize them if they really need penicillin. And that this doesn't have to be done just by an allergist. We'll never get it done if it's only the allergist doing it. It can be aided by a PharmD, and it can be a quality improvement thing that you do in your hospital if you're looking for a quality improvement project. Pearl number 9, when is a drug reaction not dangerous? And when can you treat through it? I'm going to teach you about the simple exanthem. The simple exanthem is by far the most common drug rash. These are people who look like they have measles, but they're not sick. They might be itchy. It's a maculopapular rash, looks like the pictures, usually 7 to 10 days after the drug is started. Simple exanthems, however, by definition, have no worrisome symptoms because other things can have exanthems that go with them. So what do I mean by simple, no worrisome? No fever, no mucositis, no bulla, no targets, no urticaria, which is a true allergy, no skin pain or duskiness, and no extensive pustules. If you got no, you're dealing with a simple exanthem. And why is that important? Because you can continue that antibiotic to finish your 10 days or your 14 days as long as you keep observing the patient. You also don't label this patient as allergic to that drug automatically in their EMR because we know that if you re-challenge them with that same drug, they may not have an exanthem. We don't really know the mechanism of exanthems, but it may have something to do with viral reactivation. Patients and doctors have difficulty with this concept, and you do need to explain it to your patient. Otherwise, they'll say, oh, but doc, I had that rash, but that rash may not have been a true allergy. Okay. Then we switch to the SCAR. I want you to know the lingo. SCAR is severe cutaneous adverse reaction. And severe cutaneous adverse reaction is our nickname for these hypersensitivity reactions that are very dangerous and fortunately uncommon. These are the more common ones of the uncommon ones I want you to know about. These, you will recognize, are the same things that the patient with the simple exanthem doesn't have. So when a patient calls your office and says, doc, I'm having a reaction, I don't know what to do, your receptionist, not your receptionist, your RN can ask them these questions and help you to decide whether or not this patient needs to be seen immediately. Or if the ER doctor calls you and says they have fever, systemic symptoms or prodrome, lymphadenopathy, mucosal involvement, that's a big one. Bulla, targets, pain in their skin, severe pruritus, purpura, all of those things would say we're not in the simple category and this patient needs to be seen. This little slide is just to remind you that these scars happen on all sorts of different timetables. They don't all show up in 2 days. Some of them can. They don't all show up in a week. Some of them can. Things like DRESS often take 3 to 6 weeks to start. So remember that depending on what reaction it is, it may be a drug that you started 2 or 3 months ago. All right, pearl number 10. If you suspect a scar, it's the need for speed. This is a patient where when they say yes to any of those questions that you ask them, you evaluate them immediately, maybe in the ER, because they often need to be hospitalized as these conditions tend to be rapidly evolving, and they need to be watched closely. Your basic blood work should always include a CBC with diff, because a diff really helps us beyond just what the CBC shows in knowing what pattern it might be following. And don't be afraid to be the brave one that stops all of the unnecessary drugs and all of the drugs instead of trying to second guess, well, it's got to be the new drug, because sometimes it's not the most obvious choice. The thing I forgot to put on this slide and I feel bad about, don't forget about OTC drugs. NSAIDs are actually on the list of drugs that can cause serious drug reactions, and you always have to know what the patient is taking at home as well. Follow the best expert advice for treatment, and then these are people that truly are labeled in their EMR, and even their families are told about these reactions. Okay, it seems like everybody, at least at home, very commonly we see so many patients on immunotherapy these days for treatment of their cancer. These are the checkpoint inhibitors that you hear about. And when patients take these drugs, you know, they take them for a long period of time to manage their cancer. And we do expect immune changes in autoimmunity since these drugs take the brakes off your immune system, as we say. But I want you to know that skin reactions are not only often the earliest side effects that we see, but often the most frequent. There are so many different kinds, we can't cover them, but do be suspicious that it is from the immunotherapy, and know that many of them we can manage. We can keep the patient on their immunotherapy so that their cancer treatment can be continued. Some of them are too dangerous and we have to take them off. All right, once again, the timetable. Some of these immunotherapy rashes are delayed by as much as 18 months. When people get bullous pemphigoid, it's often a long time after they've been on the drug, so don't be fooled just because it starts later. Okay, what about good old-fashioned chemotherapy? I know you may not be prescribing the chemotherapy, but you certainly have patients who struggle with it. The term toxic erythema of chemotherapy is kind of a broad term we use in derm to say those old dose-dependent cytotoxic chemotherapies where the patient gets a skin reaction that's painful, that we don't know how to treat because the damage is already done. All we can do is hold the chemo or lower the dose. But we do have some new things for treating TEC, and I want you to be aware of that. So now most of the time we tell our patients when they've gotten cytotoxic chemotherapy to shower as soon as they can after they've had the chemo to get rid of any drug that has made it to, sweat glands, hands, feet, axilla. We also ask the oncologist if they can wear cooling gloves or even a cooling hat to keep away the antigen effluvium from chemo. Know that your oncologist will not allow that if it's a liquid malignancy like leukemia because it circulates. But if it's a solid malignancy, they may allow that. And then the newest thing is, this is not proven by double-blind random control trials, but it does appear that the second the patient has discomfort in their skin, if we give them high-dose vitamin D and repeat it in a week, that they can heal an awful lot faster and mitigate a lot of the pain and suffering. And sometimes the need to decrease the dose. Okay, psoriasis. I apologize for moving fast, but that guy gave me 50 pearls. Psoriasis is a systemic disease. That's the pearl. We are learning that the chronic, in some people it's mild enough that you don't really need to worry about this, but psoriasis in general, we are learning, creates a sort of chronic immune cascade that can affect the patient in many ways, including increasing as an independent risk factor their mortality from cardiovascular disease. Some studies have shown that the life expectancy might be lowered by as much as 5 years in a patient with untreated active psoriasis. What we don't know yet is whether or not treatment will mitigate that risk entirely. If I treat your psoriasis so you have nothing, will you live longer? We don't know this yet. The studies aren't completed yet, but we kind of intuitively believe that treatment is going to improve their life expectancy. And it turns out that at least as dermatologists, we all tend to underscreen. We don't ask these questions about their other risk factors, their family history, whether or not they're up to date on their screening. We tend to ignore it, and until we get better at it, we're counting on you. So if you see a patient with psoriasis, these are patients in particular that you want to know, guided by expert opinion, that you want to know that their blood pressure is tightly controlled. You want to be on top of that. You want to be on top of their hemoglobin A1C and treatment if needed, and you want to be on top of their lipid panel and treatment if needed. So we may be relying on you without even asking you to pay attention to that, but if you can remember, your psoriasis patients need this extra care. All right. The second thing you can do as a primary care doctor is to think about screening for psoriatic arthritis. They tell us 50% of cases of this inflammatory arthritis are missed by our primary care colleagues. And the reason for that is it usually goes along with psoriasis that is obvious and already diagnosed, but it can rarely occur alone. And the psoriasis could be mild. Maybe the patient doesn't even complain about that. It is generally delayed by a few years after the onset of psoriasis, and it can involve the axial spine as well as the peripheral joints. Hands and feet are very common. There are several patterns. So in its worst phase, you will see what's called the sausage finger. The sausage finger in medicine is called dactylitis. It's when all three of your MCP, DIP, and PIP joints are swollen at the same time in a digit, so a sausage finger or a sausage toe, and that is indicative of psoriasis. It also is the condition where you see enthesitis. Enthesitis is when you have pain where the tendon inserts into the joint, so if you squeeze the Achilles or squeeze the fingers together, it will often be painful in a way that palpating the joint is not. This is a mutilating arthritis. This is why we don't want to miss it. So here are your clues. Obviously, like all inflammatory arthritides, you ask people, does it take you 1 to 2 hours to be able to walk or move? Does it really hurt in the morning for a couple of hours? Because that indicates inflammatory arthritis. Ask about their personal family history of psoriasis. Examine not just their joints, but their large entheses, their Achilles tendon, their elbow, squeeze their fingers. Look for nail pitting. It's not universal, but nail pitting and changes in the nails often go along with arthritis and psoriasis. And then look in their umbilicus, their scalp, their natal cleft for like little clues to psoriasis. And don't expect labs and x-ray to give you the answer, because they won't. They'll largely be negative, even in a case of a patient being severely affected. Okay, I know you see hidradenitis suppurativa because this condition is now increasingly prevalent, perhaps mimicking the obesity epidemic. We don't really know. But hidradenitis suppurativa, I want to teach you, is a chronic inflammatory, not infectious disease. It's inflammatory, marked by follicular occlusion, follicular rupture, and then the formation of epithelial-lined sinus tracts and tunnels that form in the intertriginous areas, the underarms, inframammary, and groin. The prevalence is now estimated at 1%. Tremendous variation in morbidity. Some people aren't bothered. Other people need to be on multiple medical regimens. So what are you looking for when you think a patient might have hidradenitis? Because Lord knows we all see people who have staph boils and folliculitis. Well, what are you looking for? You're looking for, first of all, blackheads or comedones or double comedones in these areas. People with infection don't get this. So it mimics acne, if you will, in these areas in its early stages. Then you see nodules, then you see more recurrent abscess and nodules, and then you can see a sinus tract formation. All that means is that the nodules and the abscesses start to look oblong. They look like they're moving sort of sideways instead of being round. And then eventually you may even see these extensive tunnels and tracts. And we always talk about rope-like scarring, where it's very kind of rope-like. All right. So, pearl number 16, HS is not an infection. Don't treat it like one. We have more tools than that. But there is some nuance, and I want to teach you the nuance. So it is prone to secondary infection because think of where it is. It's in the groin and the axilla. These are areas heavily colonized by potential pathogens. And it does cause tunnels and open wounds. So yeah, we're going to see more infections. In addition, we are increasingly learning that the reason that it doesn't act like an infection or respond to antibiotics all the time is that it has this very complex biofilm in the tracts. That biofilm has anaerobes in it. And you know, biofilms are very sophisticated and difficult to eradicate. And so that's part of the reason why, is that there's a lot going on in those tunnels other than a pure pathogenic infection. So here's how we manage it. We always use topical antimicrobials, chlorhexidine or benzoyl peroxide, to wash away as much as we can. Antimicrobials are great because germs don't become resistant to them. We use judicious antibiotics when needed, often guided by culture if a person has a secondary infection. But more importantly, we use intralesional steroids to calm it down into a nodule, and we use increasingly more and more of like systemic anti-inflammatories like anti-TNFs. I also want you to know that there is a change. This is my only surgical slide, because there is a change in managing this disease where we're trying to get away from waiting until they're so bad that they need to have their entire axilla removed. And we are trying to get away from the IND, because it turns out IND is not very effective. And there are a couple of office surgeries, if you're surgically inclined, that you can learn to do that really help these patients. So under general anesthesia, you can de-roof the tunnel if you're kind of a brave person who understands this concept. In order to de-roof the tunnel, you have to probe the tunnel when they're numb with a glass rod. You got to find the whole length of the tunnel. Then you open it with a scalpel. I can even do this, and I'm not a surgeon, okay? You open it with a scalpel, you curette out the base of it, get all the biofilm, get all the epithelium out of there, because remember, it's a tunnel of skin. And then you leave it to heal by secondary intention with simple wound healing. And this usually will lead to it clearing up and going away in that one area. The second thing you can do if you're a little more timid is, instead of an IND with a number 11 blade after they're numb, you can use a large punch biopsy, like a 5mm punch biopsy, right into the nodule. This doesn't work so well in a tunnel, but it works with a nodule. And you put that 5mm in, let it drain, and then immediately put the gauze over the top of a Q-tip, insert it in, and scrape it around, almost like you're trying to get all of the biofilm and epithelium out that you can, and leave them to heal by secondary intention, and that patient will heal much faster and more completely than an IND. Okay, there's just a typical tunnel, see how it's oblong, and then the kind of simple schematic of what it looks like before you open the tunnel, and then it's just open to the air after you're done. All right, this one is a long list. I'm sorry for the long list, but of course this disease has lots of comorbidities. And in a dermatology office, we often don't have time to ask about all of these things, or whether or not they've ever had any issues with this. We do often talk about stopping smoking because it's a really big flare. But if you, as our partners, know that patients have bad HS, often have comorbidities, that does help us. Okay, pearl number 19. What if you see this? This is called a knife-like split. A knife-like split is so characteristic. When we see it, we think one thing as dermatologists. A knife-like split is a clean, shallow or deeper ulcer found in the genitocurial fold, in the inframammary fold, or most characteristically in the gluteal fold. And they look icky. They look like some big ulcerated pilonidal cyst, but it's not. It's an extracutaneous manifestation of Crohn's disease. So if you see a knife-like split in a patient, you should have your suspicions raised for that. Okay, now we're going to talk about non-melanoma skin cancers. So non-melanoma skin cancers, we all think about squamous cell carcinomas coming from the sun, but a lot of my tips have to do with a patient that has a skin disease or is immunosuppressed. So one of the things we want you to recognize is that squamous cell carcinoma can also arise in skin that has been chronically irritated over and over and over again. And the reason that this is important is they tend to be some of the most dangerous squamous cell carcinomas that lead to the patient's death. Anybody who's ever seen a patient with dystrophic EB knows that that's what they die of, is squamous cells on the left that develop in the chronically blistering skin. But this is a patient who has a squamous cell on their left buttock from hidradenitis suppurativa, and I've seen this 4 times in my career. That means it's not rare, and they are dangerous squamous cell carcinomas. You can also see them arising in oral lichen planus, in hypertrophic lichen planus. So when you see a patient who has this chronic skin disease in one area, it just doesn't look right, think about the possibility of squamous cell. Here's a patient with discoid lupus, just like we saw earlier, with a squamous cell carcinoma growing on the lip. You wouldn't expect that to occur in an African-American man, maybe, unless you knew that it comes in discoid lupus. Okay, pearl number 20. All your transplant patients, solid organ, hematologic, and all your cancer survivors should be sent to a dermatologist at least for initial screening and usually ongoing screening. Why? Let's just use solid organ transplant as an example. When they have ongoing immunosuppression, it is estimated that their risks of squamous cell carcinoma are as high as 200 times the normal rate. So they need frequent and careful examinations. And that is something that you can do. Most of them are plugged in by their transplant surgeon, but you might find those who have fallen off the bandwagon. And once again, the reason for this, there's additional things that will make you more risky, like having very fair skin, but it's the immunosuppression that is really the problem. And what I want you to know is not only is it more frequent, they're more aggressive, and they're fairly commonly a cause of death in patients. Okay, pearl number 22, beware of the painful little skin cancer. If you see a patient who has a lot of little keratoses and they say, "Doc, this one really hurts when I touch it. This one," or maybe even they hurt spontaneously, that's usually indicative of the fact that this patient has a squamous cell invading their skin and not just an actinic keratosis. So pain is usually an indication of a need for a biopsy and not liquid nitrogen. All right, and don't forget about oncogenic HPV. Not all skin cancer comes from the sun. We all are exposed to oncogenic HPV. It's just a matter of luck, whether or not your body fights it off or whether it is a problem. And if you are immunosuppressed, it is definitely more likely to be a problem. So that means you have to look where oncogenic HPV can be, and that includes in the genital area, inside the mouth, and in the nail folds where we tend to think about having warts. So don't forget that unresponsive wart in the nail fold or that plaque of white, specifically if it's a little indurated in the mouth, is important. Okay, there are options for treating your basal cell carcinomas. We dermatologists used to advocate, you treat every basal cell in every patient. And this slide is just to remind you that you, as the primary care doctor, often know best. Basal cells very, very rarely metastasize, and they're not dangerous. They're locally destructive, but not dangerous. So if the patient has a limited life expectancy, if the tumor isn't bothering them, you should feel free to even work with that patient in shared decision-making to just say it's okay to do active surveillance. Don't feel like you're breaking some rule. We are increasingly recognizing that elderly patients don't always need the same aggressive treatment that other patients do. Melanoma pearls. There's so much in our literature about genetics. It is estimated that 5 to 10% of patients with melanoma have a genetic risk that is germline, meaning it's in every cell of their body, and they may share it with their family members. These are the important people to recognize because, A, if you know that's what they have, their family members can be screened and tested, and B, most of these germline mutations go along with other cancers, some of which are pretty sneaky, like pancreatic cancer without a lot of good screening. So if you know the patient has CDKN2A mutation, you know you've got to be on the lookout for pancreatic cancer. So who do you send to a genetic counselor? The genetic counselors of the world, by the way, are very overwhelmed but you send anyone who has had 3 or more. Oh, by the way, I think I have to go back a slide on this one because this is maybe important. No, I'm just going to tell you. People who have genetic cancers tend to get them earlier in life, melanomas, earlier in life, multiple members of first-degree relatives, so parents, children, siblings, all on the same side. And they tend to get them earlier in life, and they tend to be multiple. So that's the mark of a genetic risk. And so you send anybody with a history of 3 or more invasive melanomas, or even just 1 invasive melanoma, but 2 first-degree relatives on the same side of the family who have also had invasive melanoma, or one of these other cancers that we talked about. The one I always ask about is pancreatic. Okay, and then screen them more appropriately and more aggressively. All right, nodular melanomas, they are still our problem. You all know melanoma is epidemic, but the epidemic seems to be largely for those who have thinner and earlier melanomas. A lot of in situ melanomas are being diagnosed. Now, technically, they're not dangerous because they haven't even invaded. But nodular melanomas are still 20% of melanomas, and they are dangerous. They vertically grow, and more importantly than that, they often do not follow the ABCDs. They're not asymmetric, they're round. They're not always black, sometimes they're pale, but they tend to grow quickly. And the good news is that the paper shown here says that in at least half the cases when somebody showed up in an office with a nodular melanoma, they knew it was trouble. They or their family member had noticed it. So pay attention to what the patient says. The standard for biopsy and referral of a nodular melanoma is really as soon as you can get it done, like 2 weeks to get them biopsied because they're that dangerous. All right, immunobullous disease. If you see elderly patients, you see immunobullous disease. Bullous pemphigoid is the most common one. It is autoantibody mediated. Your body makes the autoantibodies. They attack the basement membrane. It is very common in elderly people, and it rises with age. It is a miserable disease. They are crazy itchy with large serous bulla that are very inflamed. It tends to be more on the trunk and sort of in the flexural areas. Here's another drug. Turns out that a lot of drugs, the one that's at the top of the pyramid for bringing on bullous pemphigoid in elderly patients is gliptins. And that's an important thing to know because often it's delayed and you don't even think about it. I started the gliptin on the patient for their diabetes, 6 months ago, 8 months ago, and now it's causing this. And in order to get better, people need to be taken off the drug, not just managed with more prednisone. And then here's a slide that oh, well, not this one. This one is just reminding you, we see bullous pemphigoid because it's autoimmune and immune checkpoint inhibitors too. And this is one where we tend to use this drug called dupilumab, which is actually a drug approved for atopic dermatitis, but it's just kind of an aside slide about how we manage that. Okay, if your patient with bullous pemphigoid isn't getting better, you have them on prednisone, immunosuppressive, whatever, they're not getting better. It turns out that 90% of them are colonized by TSSA, by MSSA, pardon me, and that they improve when you give them a short course of doxycycline. We wonder if that's why doxycycline has worked in treating some patients with bullous pemphigoid as a non-steroid adjunctive drug. They don't need to be on it for long, maybe 3 weeks, but it can make a big difference. And then lastly, I'm passionate about this. We know that there is increased mortality in our bullous pemphigoid patients. They tend to be elderly. They are often frail. And the old paradigm was slam them with prednisone, a mg per kg, and if it doesn't work, double it. I kid you not. That was when I was a young doctor. We probably have to admit that our disease-specific therapy is part of the reason that these patients have increased mortality. Try never to start with more than a half a mg per kg and taper as soon as you can. Try to substitute another immunosuppressive drug like maybe mycophenolate if you really need to. And use topical therapy with a potent clobetasol. You're going to thin their skin, but it's better than giving them systemic steroids. So if they have limited, you can use topical steroid. Okay, don't forget that there is more than one mucous membrane than the mouth. Many diseases that our skin affect the mucous membranes. And sometimes people say there's nothing in their mouth. Well, nose, sinus, eyes, esophagus, genitourinary, perianal. This is just an example to remind you of lichen planus with the lacy look on the lip, and then the erosions in the mouth and on the tongue can also involve the esophagus. And this is really hard to treat, but if the patient's telling you they have pain, you know, it means that we have to have somebody look for this. Okay, granulomatous disease. Cutaneous sarcoid, very common. It's often the place we get the biopsy comes from the skin and it proves the naked granulomas, and this patient has sarcoidosis, and you don't need to go after any other tissue. But when it's in their skin, there's a pretty good chance that it's somewhere else in their body, and everybody with sarcoidosis needs a systemic workup every time. This is probably the one exception we learned about, Lofgren's syndrome, which I haven't seen in a long time. That's when patients get hyaluradenopathy. And technically, they don't get cutaneous sarcoid, they get erythema nodosum. And then it goes away and all the sarcoid is gone. This is the one that is often self-resolving. I'm talking about this kind of sarcoid, papular, bumpy sarcoid, hypopigmented sarcoid, annular sarcoid. We always call it the great pretender. It can come in scars, it can make scars, it can be subcutaneous. It can look like a butterfly rash, only really hard to the touch. It can come in your eyes, causing uveitis or see the swollen lacrimal gland. Whenever you prove it in the skin, you're not done. And the things that people tend to forget about are the TB screening to make sure there's no TB, the referral to ophthalmology, and most importantly of all, the referral for at least a baseline EKG. And if your patient complains of palpitations or shortness of breath when they run for the bus, they need more than just an EKG, because these patients die of sudden death when they have cardiac sarcoid. Okay, there's always something new in town. I tell you about this because it comes from my institution, and I want you to hear it before the rumors get out. So we all know that rubella is a, pretty significantly at one time epidemic and endemic viral disease that was particularly challenging in the congenital variant, where children often were affected for life with serious conditions. We know that since 1979, we have had a rubella vaccine that is a live, attenuated MMR, measles, mumps, rubella vaccine that we've been using since 1979. We know it's crazy effective. It's wiped out, 95% of people seroconvert when they're vaccinated. And in 2004, endemic rubella was declared cured in the United States. We didn't see pockets of big outbreaks anymore because of the vaccination rate. But we also knew that you couldn't give this vaccine, because it's live and attenuated, to children with immunodeficiencies. What we didn't know was that sometimes it shows up in people who are clinically immunocompetent. So this patient on the right is my immunocompetent patient, and she had these unexplained necrotizing granulomas in her skin. And to make a long story short, after seeing a number of these patients at several institutions, the CDC finally determined that there was wild type and vaccine-derived rubella in the macrophages of these granulomas driving the disease. So this slide is complicated. Go back and look at it later, but it's not just the vaccine that gives people these immunocompetent people on the surface, that gives people these unusual granulomas. It's also the real virus. We have found wild virus. So please do not take this home and say, oh my gosh, we can't give MMR vaccine anymore. Someday, hopefully, we'll have a better vaccine that isn't live and attenuated. But in the meantime, don't forget how successful this vaccine has been. I just want you to be aware of it. And if you have patients that you think have this disorder, you can contact me. Okay, retiform purpura. You stand at the bedside, the patient's got bleeding into their skin. Obviously, you want to know the timing, you want to know the size of the lesions. Do they look like they're big, small, or medium? Are they palpable, indicating maybe vasculitis or inflammatory purpura? And what is their shape is what I want to teach you today. Pepper of petechiae, bruises of ecchymoses, palpable purpura, vasculitis, and then this funny shape. So that funny shape is what we call retiform purpura. It looks like spikes, okay? What does it mean? It means there is occlusion in the vessels. This occlusion can be from bland thrombi in the setting of DIC or without DIC. It can come from gelled cryoglobulins, emboli, angioinvasive infections, or from calcium in calciphylaxis. And what I want you to concentrate on here is just the spiky nature of the periphery. So when you see this on a patient, you'll say, that's occlusion, that's occlusion, that's occlusion. And then you have to figure out what gave them the occlusion. Here's occlusion from Pseudomonas growing in the vessel. Here's occlusion from cryoglobulins. See the retiform pattern. Here's occlusion from calciphylaxis, which is when calcium deposits in the vessels. And one of the rare kinds of vasculitis that can give you this retiform look, which is polyarteritis nodosa. And here's retiform from cholesterol emboli. All right. Actinic purpura, on the other hand, this is one where you get to reassure. Patients come in and they say, Doc, I get these huge bruises all over my arms and my hands. You got to check my blood. There must be something wrong with me, or it's from my warfarin. And you can say, nope, this is actually from sun damage. We used to call it senile purpura, and now we call it actinic purpura. People don't get it on their stomachs. They get it on their arms and their hands. And it's these large, purple, weird-looking bruises, and you can reassure them that it's just from their skin being thin, not their blood being thin. Okay? Infectious disease. Don't miss the chance to diagnose the great pretender. I think you're getting a talk about syphilis. It's on the rise. It's been on the rise for decades, especially in the young teenagers, especially in men who have sex with men. Did you know that using PrEP is also a risk? PrEP is pre-exposure prophylaxis for HIV because it changes people's psyches and their risk behavior. So you got to think about all of these things when you're wondering who's at risk. But you have 3 real opportunities, I think, to be a real hero when it comes to syphilis. 1 is to diagnose the chancre, given the opportunity. 2 is to diagnose secondary syphilis. And 3 is to never, ever, ever be a part of a team that misses congenital syphilis, which I also think you're getting a talk about. So the chancre, why is the chancre so hard? Because, first of all, it tends to come on genital skin, so people don't want to call their doctor. Second of all, it is painless, so they don't call their doctor. Third of all, it can self-resolve in 1 to 3 weeks. So they have an appointment, but now it's gone, so I cancel, okay? And fourth of all, even if you see them and run the labs may not be positive yet. So this patient could be missed. But if you see an indolent, painless ulcer in a sexually active patient, even if their tests aren't positive, you probably want to treat them. If you don't, nearly 100% will go on to secondary syphilis 2 to 8 weeks later. And some of these patients have no symptoms at all besides skin rash. 80% have a skin rash. That's your chance to diagnose. Some of them have other signs and symptoms, but many of them don't. So what are you looking for? You're looking for that papulous squamous, scaly, bumpy rash all over the body, often with that collarate scale that you see in the center one, that little peeling scale at the periphery, often on the hands and feet, sometimes in their mouth with mucus patches, sometimes looking like big genital warts in the groin, and sometimes these weird annular patterns. So this is your second chance to diagnose syphilis. In this case, the test will be positive. And why is congenital syphilis so important to screen for? Quite simply, we all know what we're supposed to look for in the infected infant, but the majority of infants do not have obvious congenital syphilis at birth. So if you're just going by your ability to recognize it and diagnose them, we're going to miss. Okay? How many of you have ever seen the measles? Some of you? Maybe when we were younger. I mean, I had the measles. We have to be looking for it now. Remember the 3 C's, cough, conjunctivitis, and coryza. Remember that the rash usually starts on the head and then moves down, and that you can see these Koplik spots. If you think you're seeing this, your office is infectious for 2 hours after the patient leaves the room, and it is probably one of the most infectious viruses out there. So hopefully they don't come into your office and then show you these things. But you do need to know the measles and be watching for that. Pearl number 37, I know we're getting close here, Adam, but there's a lot of pictures. 37, not just pediatricians should do vaccines. I have to do vaccines a lot because I immunosuppress people. with medicine, but we all need to be aware of what vaccines are recommended for what age people and special groups. So don't forget about that. Pearl number 38. How many of you have been fooled by lower extremity cellulitis? I mean, me many times. It's very easy to be fooled. Perhaps one of the best clues is unilaterality. Bilateral cellulitis is very rare. But this is just a list and some pictures to show you of, well, if it's not cellulitis, what is it? Because sometimes we stop thinking there. It could be stasis dermatitis. It could be lipodermatosclerosis, which is fibrotic stasis dermatitis. It could be allergic contact derm. It could be a DVT. It could be paniculitis or lymphedema. This one I think we're going to skip because it's just not that important, but it's showing you the difference between Candida and tinea, and I think you probably all know that. But this pearl, I want to remind you that yes, we are now seeing new Candida and new tinnias that are resistant to all of our drugs. And even the strains of Candida and tinea that we've had in the United States are increasingly resistant. What can you do about this? Not everything that is annular is tinea. Don't treat it forever with oral or topical if it's not responding, and tell your patients the same thing. Don't overprescribe oral azoles for chronic Candida prophylaxis because this is the setting where we're seeing a lot of resistance. And when you're treating tinea, try not to combine the topical antifungal with a strong steroid. In that setting, those combination drugs, we tend to see more. Okay, acanthosis nigricans, when you see this velvety change on the back of the neck or in the axilla, I want you to think insulin resistance. We used to think, oh, that patient is obese, that's what it's from, or from a rare endocrinopathy or malignancy. But really, it indicates insulin resistance. So these are the patients where you need to be on top of their hemoglobin A1C and perhaps even more than that. I know there are more sophisticated tests than that. Here's a rare mini pearl. If you see acanthosis nigricans with a tripe palm where it's on their palms, 100% of the time that patient has a malignancy. So that's the exception to every day. This is very rare. All right, adults get atopic dermatitis too. 7% of adults get their atopic dermatitis as an adult, not being left over from childhood. And just don't forget about it. Sometimes it has a real head and neck distribution, but these patients are miserable, like kids can be miserable, and we have many more drugs to treat them than we used to. Okay, how do I know if I'm dealing with CTCL? Well, first of all, don't worry, because it often takes us many biopsies to diagnose it. But if the rash that isn't responding is on the breasts or the covered areas of the buttock and the upper thighs, that's a clue. If it has a geographic shape to it, that's a clue. And if it's atrophic, that's a clue. Because we don't normally biopsy dermatitis. We don't learn a lot from biopsying dermatitis sometimes. But if you have these rashes on somebody's buttock and upper thighs or breasts that aren't going away, you should think of CTCL. Okay, have that Jobst prescription thing ready to go, because there are so many things with patients' legs that get better than just venous stasis and venous ulcers. If they've had cellulitis, you should get them in a support stocking. If they've had vasculitis, you should get them in a support stocking. Support stockings can really help people get over these things. All right, when do I treat the weed and when do I treat the field when people have sun damage? Well, the weed is the liquid nitrogen, spray one at a time. But look at the guy on the right. You can see that there's sun damage all over his cheek. You can see it on this person's forehead, that there's sun damage all over his forehead. And then on the right, you see a patient who's well into their topical 5-FU for their sun damage. You can see how many AKs there are that light up. So remember to look closely before we just think that all they need is a little spot liquid nitrogen and consider treating the field. These are the things that we generally use to treat the field, if you're not familiar. Okay, we're getting there. Seborrheic keratoses, they're so common. Doc, I got these. First of all, don't call them moles, because what you want to tell the patient is that they don't have a malignant potential. So they're not moles. They're seborrheic keratoses. Second of all, remember that you can't treat them unless they're very, very irritated. You can't bill them to insurance. But when you send a patient home and say, well, just, they're nothing, that's wrong, because this is a very difficult self-exam, and this is a very difficult exam for us. So When you have them in your office, you have to look carefully for the melanoma that may be hiding on that back between the seborrheic keratoses. So don't dismiss them and saying, don't worry about these. You still have to worry about all their brown spots. Okay, pearl number 47, adults get genodermatosis. This is important for two reasons. It's born in your germline, but often the skin findings for it don't appear until later in life. Katie's written stuff about this with me. It doesn't appear until later in life. So we think genodermatoses are going to show up in a baby, but they don't often until later. And why they're important is because many of these genodermatoses are associated with cancer. For instance, this is called Reed syndrome on the right, and it goes along with these cutaneous leiomyomas, many of them. So when somebody has a whole lot of benign tumors, or they say, yeah, my brother's got these too, you should be thinking, what could this be a sign of? Because it's not normal to get many benign tumors like this, okay? How much cream do I order? This one is just kind of in sympathy with you. How do you know how much cream to order? Well, there's two important things to remember. Well, several. How many times a day do they have to put the cream on? How many days do I expect it to last, or can they refill? How much of the body am I going to cover? And then you need to know that 1 ounce will cover the average adult once. That helps you do the math. 1 ounce, 30 grams is one application. So obviously you need a lot more than 30 grams. This slide, if you just like kind of copy it and put it in your office, we call it the rule of nines. But it's basically 9% of your body surface area is the front of your leg. 9% is the back of your leg, 9% is the front of the other leg, and you can see how it all adds up. So if you're just treating the lower legs, it helps you to know how much cream they need to cover that body, okay? Tips for melasma. Melasma, it turns out, which is common, we always thought of it as coming from the sun and hormones, but in fact it also comes from visible light spectrum and from infrared light. So if you have a very hot job, or if you work in very bright lights, your melasma can get worse even if it's not ultraviolet. These are patients where at best right now, besides treating them, we tend to tell them to buy sunscreens that are tinted, because that is iron oxide in the tint, and it helps to keep the visible light from penetrating the skin. So it's a quick and easy tip for your melasma patients. And the final slide, we made it to the final one, and I am 4 minutes over. But the final slide is a biopsy is always fraught with difficulty. It is, first of all, a guy's opinion, and they're probably much smarter than I am, but it is an opinion, and they can only work with what you give them. So if you have given them a specimen that is inadequate, too shallow, too narrow, or if you have given them a specimen that was taken too early or too late, you are going to miss the diagnosis. That's why we always say having a biopsy that says no vasculitis doesn't mean the patient doesn't have vasculitis if you looked in a different time frame or a different place. So always read your biopsies with a degree of sort of humility and saying you can't always tell the full answer from that. Thank you very much for your time. Yeah, thank you.
Because we're a little bit behind, maybe we'll have Dr. Wilson go out in the hall to answer any questions that might be.
I'll be here all afternoon if people
awesome.
have questions.
And I think she cheated a little bit. I asked her for 50 pearls. I think she had like 245 is what I counted. So which is awesome. So thank you so much. She is an absolute gem. Just for a way of information, the movie night tonight we will not be distributing tickets. They'll have a list of names of people that are going to be there, and they'll mark them off as you come. So the earlier you get, the better seats you'll get. If you have a bigger group and you come late, there's a good chance you'll kind of be scattered among the theater. So, and then also the medical bookstore is out this way. Please make sure you just stop by, talk to them. We would love to have them